What point will we know whether we have a quorum or not?
So very recently, we had to switch to include the Zoom. So I think several people will be joining on Zoom, but we can give it a few more minutes.
Mondays are always a horrible day for lectures.
I'll let this start today.
Discharges, people picking up new services. I picked up 23 today at Erlanger and then some at Siskin. How many of the residents have come down with the COVID? Is it-
Yeah, I think there's been at least 5 that I know of.
I'll survive.
Me too. Approved at 55, you can survive it, so. Wasn't too bad. Weird thing is I had no respiratory symptoms. I was just fevers and muscle aches and chills.
I didn't have any, like, when I had COVID back in March of 2020, I didn't have respiratory symptoms either. Basically, this was exactly the same, just not as bad, but still, I get tired of hearing that now term, because,
It gets your attention.
yeah, so.
For me, it was just the end of the day fatigue for about 3 or 4 days where I was,
Still lingering.
I'd get to about 3 o'clock in the afternoon and I was just out of gas.
I get a solid 8, 9 hours in, and then it just starts the little brain fog-ish, the fatigue, and it's like back when you see, like, you feel. My brothers and mother-in-law though have the combo of corona and the flu. So,
That doesn't sound good.
no, and they didn't know she had influenza. She didn't test positive when she did for COVID at first, but everything just kept lingering. It wasn't fading off or anything. They took her back in, and that's when she got positive for influenza. So.
What's that?
How was your holidays?
Well, other than having the COVID, it was all right. So and I happened to have it while I was on vacation. And I got back from vacation and Stafford was supposed to be rounding with me at Erlanger and he got COVID. So then I got to do my rounds and his rounds. I got doubly screwed. And he had his full vacation and then he got off. I did it ass backwards.
Sorry. But enjoy you.
Yeah, it's just my luck. I don't want to jinx myself, but I've been 15, 20 years. I haven't missed a day of work for sickness. But when I do get sick, it seems to happen like that. It's when I'm already on vacation. I was just at my house. All right, I think we can get going. All right, well, sorry for the Monday lectures. What I thought I would talk a little bit about is some of the things that I do behind the scenes that you guys never see. I mean, you see me rounding, doing the dialysis side and the consults for acute kidney failure and things like that. But the main job that I do in the outpatient setting is taking care of transplant patients and then looking at folks who want to get a kidney transplant. And y'all are going to run across many transplant patients across many different specialties. They're everywhere, whether they've got hearts or lungs or kidneys. And there's still a lot of confusion about, what we do for a living, who's actually candidates, why do we even worry about trying to decide who's a candidate or not, what kind of testing we do. So I thought I would just kind of give you an overview of some of that. ThinkPad. So just a couple of basic facts. One of the things that we do need to realize is that a kidney transplant is just a form of a renal replacement therapy. It's not a cure for kidney disease. It's another way of managing kidney failure. And like all therapies that we have to offer for people, there's benefits and there's risks of them. And a kidney transplant is not the therapy of choice for some patients, and for others it is. The transplant surgery itself puts people at risk early on for increased mortality. There's risk of anesthesia, there's risk of bleeding complications, there's the cardiovascular stress from a major vascular surgery. So we'll look at a little bit of the data, but we want to make sure that if people are going to undergo kidney transplantation, that they can handle the surgery part, and they're going to live at least for 220 days, and then they'll start to see the benefit from transplantation. The other thing we have to realize is that kidneys are in short supply. So right now there's over 100,000 people that are on the list waiting for kidney transplants. And we do about 16,000 transplants every year in terms of mixtures of kidneys and live donors. But the list keeps growing, so there's a shortage of organs. And the waiting times for kidney transplantation have gotten more prolonged. So if you're a B blood type or an O blood type and you're unsensitized, meaning you don't have antibodies against human leukocyte antigen tissue, your average waiting time for a kidney is about 7 to 9 years. That's if you're trying to hold out for the best of the best kidneys. If you're willing to take kidneys that come from older donors or people who've had some damage to the kidneys, diabetes or high blood pressure, that waiting time might be closer to 4 to 5 years, but it's still quite a prolonged waiting time. And unlike organs like lung or heart or liver, there's no medical necessity for transplantation for kidneys. We've got dialysis, so we have a modality where we can keep people going. So there's no equivalent to the a grade 1, need for a kidney like for a heart. So if you got a heart failure patient who's on all kinds of pressors and on a LVAD or some kind of destination therapy, they're going to go to the top of the list for their medical need. That doesn't exist in transplant. So in transplant, you get on the list. There's a very complicated system for something called the point system, but basically you spend your time there till your name comes up and then you get it. And so the government agency that's responsible for distributing these kidneys is UNOS, and it's the United Network for Organ Sharing, and they have a grant through the Human Health and Services in order to distribute these organs, and they have a way of trying to figure out this point system for people. But basically, when we're counseling patients for transplantation, we have to not only think about, are they going to survive the surgery part, but are they going to be around long enough to even make it to where they get an organ offer? So if somebody's got a 9-year waiting period for a kidney and they're a bad diabetic with bad coronary disease, have strokes, have had some vascular disease that's putting limbs at risk, they may not end up being a candidate, even though they could make the surgery right now, but they're just not, if they don't have any living donors, they may not make it to their waiting period if they're a B or an O type. So we may not even list them, at that point if their waiting time's too long. So it becomes a struggle as a transplant nephrologist to try and decide, well, which patients are we going to select for transplantation? How are we going to guess whether these patients are going to do okay? Are they going to get a benefit from the surgery? Are they going to be able to live through the surgery? Are they going to be able to live long enough to get a transplant? What's the kind of time frame that we're looking for them to get an organ? If they may not make it to a deceased donor, is it an option to try and get a living donor if they have those? And how do we look at that? So I mentioned this increased mortality with surgery. And people have tried to pick this data apart, and it's, it's pretty difficult when you're trying to compare survival rates of different modalities. So, it's always a hard time comparing apples to apples. So when you're looking at people who've gotten a transplant, you're trying to say, well, what control group do you look at for those? So the control group would be other people who are listed for a kidney transplant, but who haven't gotten one. But there may be a variety of different reasons why they haven't gotten transplanted. They may have unstable vascular disease, so they may be going on the list and off the list in an active state. They may have some illnesses going on. So it may not be an actual true group to compare to, but it's the best group that we have. And if you take patients who are on the wait list who aren't transplanted, and then you look at the people who get a kidney transplant, there's a higher death rate early on in those that get transplanted. And that's going to be with the surgical complications. So if somebody dies within 106 days of the transplant, obviously they've had a higher risk of death compared to if they had just stayed on dialysis. Now in that dialysis time, some people are going to die, because 1 out of every 20 dialysis patients dies each year. But you basically have to live more than 106 days for the risk to start reaching equality. And what that translates to is that if you look at the survival curve, you have to be able to live about 250 days before you expect to see a benefit from transplantation. So when we're looking at people, we're spending a pretty large amount of our resources looking at cardiovascular risk, basically under the guise of surgical survival. So we're looking at presence of coronary disease, we're looking at presence of vascular disease and things like that. And we're trying to make a best guess as a physician that if they get a kidney, they're going to live at least a year, but ideally we want them to live, 5 or more years outside of transplant in order to benefit. As I mentioned, the risk of dialysis, dying on dialysis is very high. So we said there's basically about a 1 out of 20 chance of people dying in the first year of being on dialysis. And the death rate, stays pretty constant at about 250 patient deaths per 1,000 years on dialysis. If you look at transplant patients, their death rate's a lot lower than the dialysis population. So if you can get a transplant, you tend to survive longer. But it's also a little bit of a self-selecting group, because those that get transplants are healthier than a lot of the patients that are on dialysis too. So if you look at patients who are on the list for transplantation, if you have been on the list for a short period of time, your risk of dying is less than if you've been on the list a long period of time. And that's sort of intuitive and just basically points out that dialysis by itself is a non-physiologic state. There's a lot of bad things that happen when we hook somebody to a dialysis machine. There's activation of our immune system. The filters themselves are non-biocompatible. So if you look at things like adhesion markers or inflammatory markers on white blood cells pre and post a dialysis procedure, they're jacked way up after dialysis. So you get a lot of inflammation that occurs. If you think about what happens in the dialysis procedure itself, there's a lot of volumetric changes that occur. So we get these non-compliant patients, they eat a lot of salt, they drink a lot of fluid, they come into the dialysis unit, they've gained 6 or 7 kilograms over the weight that they left 2 days ago. And we've got to pull that fluid off. Well, we're pulling that fluid off the intravascular system. So let's say you've got 7 liters of blood in your intravascular system, and I've got to filter off 7 liters in 3 hours. That's risk of vascular collapse. It's a lot of volumetric changes that puts the heart under stress, and you're trying to dialyze that fluid off while you're expecting volume to move from your other third spaces into the vascular tree, but it's a vascular stress. So dialysis patients have increased inflammation, they've got increased cardiovascular stress that's going on for that. And then they have non-physiologic control of other things like their electrolytes. So we have hyperphosphatemia, we have abnormalities in the calcium phosphorus saturation points in the blood. So we get a lot of medial calcifications that lead to the vascular damage and things like that. So the longer people remain on dialysis, the higher their death rates and then potentially the worse outcomes they have after transplantation. And with that, when we look at who should get a transplant, it becomes a little bit of a ethical dilemma, because not everybody's going to benefit from transplantation to the same extent. So if you think about somebody who's in their 70s and they've had diabetes for a period of time, their life expectancy on dialysis is terrible. So, you know, when we start people on dialysis in their 70s with diabetes, you know, I tell them, you got a half-life of 5 years. The death rate on dialysis is much greater than most forms of cancer in that age group. And they're like, well, give me a transplant. I'm like, okay, I can transplant you, but the transplant's not statistically going to make you live longer. So if you look at the years of life gained with a transplant, it's only about 3 years compared to their life expectancy. So we do transplant the elderly, or at the advanced age, I should say. And the reason we do that is more for trying to buy them different quality of life. But we're really not doing it as a life-saving procedure. That's a little bit different if you look at the young diabetics. So if you look at a young diabetic and you put them on dialysis, their life expectancy is only 8 years with all these other stressors that we were talking about. But you get them a kidney transplant, their life expectancy goes up by almost 15 years. Okay. So that as a group benefits more than any other group in the transplant category. And so with organs in a short supply, one might make the argument, well, why are we even transplanting the patients of advanced age? And then that gets into all this complicated ethics about equity versus, you know, social benefit and things like that. But it is tough as a doctor that you have to try and break these numbers down for people. And when we're talking about some of our patients of advanced age, we may not put them on the list if their comorbid conditions are such that we really think it's not going to be a good use of an organ. But it's, you know, when they look at this data saying, well, I can live longer, and if they get 3 years of longer life, that may be important to them. But it's just a little bit of a struggle. And one of the things that we know, and you guys see this all the time, is that patients with renal failure are hospitalized a lot. There's bacterial infections that go on. There's vascular problems they have with poor wound healing, needing amputations, things like that. Infections that come from use of catheters and things like that. If you do get a transplant, and granted, you know, again, you have to look at all this data with a little bit of a grain of salt, because these patients are a healthier group subset of the dialysis patients. But in general, transplant patients stay out of the hospital more than the dialysis population. And mostly they're staying out of there, which is obvious because they have less infections and they have less cardiovascular risk. That seems a little counterintuitive, the less infections, because you'd say, well, you take a group of people and you immunosuppress them. Well, I kind of expect they have more. But we have to remember that dialysis is an immunosuppressed state in of itself. And it's a state of chronic inflammation. And it's a state with a lot of foreign bodies present. So if you ever wonder why we're pushing so hard to get dialysis catheters out of people and try and get AV fistulas, anytime you've got plastic inside the body, and you've seen this, and you've penetrated the skin as an infectious barrier, it's a freeway for bacteria to make it into the bloodstream and onto the heart. And there's a high rate of endocarditis that shows up in our patients who have catheters. Now, none of this is cheap. So if you think about the dialysis procedure itself, it's about $90,000 a year to the payers. And that's if you're staying out of the hospital. If you're getting hospitalized, the costs go up somewhat. But a kidney transplant's about $200,000, you know, for the actual procedure. And then the medications cost anywhere between $10,000 and $16,000 a year to payers. So if you look at the cost of transplant in the immediate perioperative period, it's higher than dialysis. But as time goes by, it becomes a cost savings to society. And so if you're looking at Medicare dollars, and end-stage renal disease is one of those diseases that's covered by Medicare if you've been on it for 90 days and you qualify for Medicare otherwise, then you get Medicare after 90 days of dialysis. So it's in society's best interest if we can lower the cost of Medicare, because it's all our tax dollars that are going into that. There's a risk of Medicare, running into financial trouble and things like that. And so if we can find a way to save money for the dialysis population, that's good. And if you think about transplant patients, if they start living out more than 4 years, then we start saving the government money as far as compared to them remaining on dialysis. So less hospitalizations, less infections, less cardiovascular risk, increased life expectancy, and it's cheaper. So it sounds fantastic. It sounds like we should be doing this for everybody. So the main barrier as far as why we're not doing this to everybody is what I already alluded to, was the shortage of the organs. And one of the unintended consequences of the shortage of organs is that as time is going by and the wait lists are getting longer, people are getting less benefit from transplantation. And that's because their body is taking on the damages that's occurring with dialysis. So back when I started in this game, we, the waiting times were shorter. People had only been on dialysis for a year or so, and so they tended to have a lot better surgical outcomes. Nowadays, I'm getting patients who've been on dialysis 7 to 8 years. They've got all the cardiovascular morbidity and that's associated with that, and the risks of death, the risks of loss of organ go up, and those risks go up even over just a short period of being on dialysis. So if you look at patients who've been on dialysis for less than 6 months, their survival rate's going to be about 60% 10 years after the procedure. But if you look at people who've been on dialysis as short as just 2 years, their death rates go way up. And then after 10 years, only 30%, have survived. So it would be in the interest of the country and for people if we could get folks transplanted quicker. And you can break this data down in a couple of different ways, but basically it all states the same, is that even as being on dialysis as short as a year starts to bring on damage. And if you look at these hazard ratios, you have a 13% higher chance of dying if you've been on dialysis for 2 years. If you've been on dialysis for 10 years, your death rates start going up by 40 or 50%. So how do we decide who we're going to transplant? Well, there's some things that make a lot of sense where you're not going to immunosuppress somebody if they've got an active infection. So, we see a lot of patients who have osteomyelitis, they've got non-healing ulcers, they might have chronic fungal infections. There's things going on that would be a contraindication to getting immunosuppression. Malignancies are another thing that I have to look at a lot. And not every malignancy is treated the same. Some are worse than others. Breast cancer is particularly a bad one. It's got a high rate of recurrence after somebody's been immunosuppressed. Other cancers are not so bad. So things like renal cell carcinomas, they grow slowly in patients. If you catch them early and they're less than 5 centimeters and they haven't spread outside of a kidney, that's a surgical cure. Those patients can go right to transplant. Whereas with a breast cancer, even if you think you've got the whole lesion out, you usually have to wait about 5 years at minimum to see if there's been any recurrence because of the rates of spread to the lymph nodes. Certain drug use, marijuana seems to be okay with patients as long as they're not using marijuana to the point that they're crashing their cars or getting themselves arrested or things like that. It doesn't seem to have any toxicity to kidneys. Alcohol in small amounts doesn't seem to do it either, but there are patients who are alcoholics who, drink to the point that they forget to take their medications and things like that. So that might be a contraindication. And compliance is a big issue for transplant. So we know that patients who don't show up for visits, who don't take their medicines on a routine basis, have very poor outcomes compared to those that do. But look at the dialysis population. How do these people get there? They basically get there through a life of non-compliance. Most of them have not taken their blood pressure pills, they've not managed their diabetes, they've not seen a physician. Some of it's personal responsibility, some of it's lack of access to care. So a lot of the patients that we see are culturally challenged, where they may come from home environments where they don't have insurance, they can't get to a doctor, they live in an area of sort of medical isolation. So some of it's not their fault, but a lot of it is just that, people don't do what the doctors ask them to do. And then there's some contraindications that are a little bit relative. So if you go from transplant center to transplant center, you might find different restrictions for people. One restriction that's can be controversial in some settings is body mass index. So I guess I can show this data. There's this funny data in the dialysis population. So if you look at the general population, obesity is related to death. So there's higher rates of diabetes, there's higher rates of metabolic syndrome, there's higher rates of cardiovascular disease in the morbidly obese population, and they die at a higher rate in the general population compared to those that are not obese. But that's reversed in the dialysis population. So it's actually an advantage to be an obese in the dialysis population. Less death. Why is that? We don't entirely understand it. It may be that it's just a marker of people who are still maintaining better nutrition. There are those patients who are not thriving well on dialysis. They've got severe protein malnutrition. Their albumin levels are in the tank. They're chronically inflamed. And maybe those that are obese are just a marker of that these people are actually eating and taking in protein and things like that. But there is a paradox here. And so normally you would say, well, should we be offering things to patients who have risk factors for death if you look at it from the general population? But actually, if you look at it from the dialysis population, obesity is not a risk factor for death. And if anything, it's a risk factor for better outcome. But if we look at organ survival rates, they are down slightly in the obese population. And that has to do with surgical complications. So if we think about a transplant, the transplant's about the size of my fist. And it's got a little bitty artery that's maybe 6 or 7 centimeters long on it, a little bitty vein that's about 6 or 7 centimeters, and a ureter that's about 10. And we've got to hook that up in the body to where the ureter could connect to the bladder and that the arteries can connect to blood flow. So, obviously our native kidneys are in our back, but we end up putting the transplanted kidneys in either your right or your left iliac fossa. And so that way the bladder is accessible and the internal pelvic arteries and veins are accessible. And so if you got a little skinny guy like me and you're trying to operate, you're operating in a hole that's maybe a couple centimeters deep. You get somebody who's a little bit thicker, and then all of a sudden, instead of operating at 3 or 4 centimeters deep, you're operating at 15 or 16 centimeters, and the arteries maybe 5 millimeters in diameter, the veins slightly bigger than that, but you're trying to sew things that are very tiny in a deep hole. And so there's a risk of bleeding complications and prolonged warm ischemia that occurs to the organ as the operation takes longer. And then if you have to make the incision a lot bigger, use bigger retractors, you have higher risk of wound dehiscence and perioperative wound infections that occur. So there is a downside to the surgery aspect for the obese patients. And we actually see this when we try and break down graft survival by body size. And this is one of these U-shaped curves that we see in medicine a lot, sort of like with blood pressure. There's a sweet spot for blood pressure that if you keep it under control, you've got a survival advantage. You drop it too low, your mortality goes up. You let it go too high, your mortality goes up. So you get these U-shaped curves. Well, the same thing happens with body mass in transplant. So if you've got somebody who has a relatively normal body mass in the 20 range, that's going to be the sweet spot for organ survival. As we get heavier, our organ survival drops off from surgical complications. As we get lighter, our survival drops off because of malnutrition complications. So when we see dialysis patients who have BMIs of 18 or below, usually these guys have severe sarcopenia, severe protein calorie malnutrition. They don't heal well, and they don't handle immunosuppression well. So there's kind of a sweet spot in that area. What about smoking? You know, there's certain risk factors that we have that are modifiable for outcomes. We know being compliant's one of them. We know keeping your blood pressure under control is another. But smoking is a manageable side effect or risk factor. And there is a cost to using smokers versus non-smokers. So if you look at graft survival, the graft survival is down by about 2 years in general in transplant for those people who smoke versus those who don't. Now, it's not broken down into how much they're smoking. So you can imagine if you've got somebody who's smoking 2 packs a day, that risk factor is obviously going to be greater than somebody who's smoking 1 or 2 cigs a day. So it's something that we have to figure in. Some transplant centers will not transplant people who are smokers. We're not that dogmatic here. You know, we basically look at somebody and we say, what's their overall gestalt? So if I had a 30-year-old who's smoking 3 cigarettes a day, and they want a kidney transplant versus a life on dialysis, then I may say okay to that person. It's a slightly higher risk, but it's not a lot. And the benefits they're going to get from transplant is going to be humongous. But if I see somebody who's 75 and they've got active vascular disease, not healing wounds, and they're smoking, well, then I may mandate that they quit. And then one of the things that's happened with transplant is that our patient population is getting older. It's getting older because of waiting times that are occurring. It's getting older because we've gotten more experience with transplanting the elderly. Our population's getting older. There's lots of risks, but if you look at the wait list, it's there's more patients who are showing up on it that are above 60 now than used to be. And age is a risk factor for poor survival of the patient. So if you look at patients that are over the age of 70, their risk of dying is going to be higher than the younger population. And this graph actually doesn't show what I was hoping it was going to show, but it's a breakdown. It shows up this one. So if we looked at just overall people early on, we saw that the risk of transplant became equal at 106 days. As you get out on the older patient, that pushes out to 125 days. But this slide's not the one I was actually hoping that I'd put on my deck. But I think we got at the data a little bit when we were looking at expected life, years of extra life added on as we get older, and it really starts to diminish as we get over the age of 70. So I mentioned to you guys malignancies, and you might get asked these questions on some patients. So there are some tumors that do really poorly with immunosuppression. So colorectal cancers, if they're invasive, have a high risk of reoccurrence. Breast cancer is one of the big bad boys. A lot of the squamous cells can behave really poorly. So women who've had cervical cancers, squamous lung cancers, some of the squamous skin cancers I actually worry about in these patients. Immunosuppression's got a very strong effect on those. Those that have had kidney cancers that have spread don't do well, but if you catch it early and you can resect it, they usually do pretty well. There's some cancers where we don't end up having any wait time at all. So if you catch breast cancer in situ or cervical cancer in situ, then that's not going to be a big deal. But if it's the true cervical cancer, that's a problem. There are some kidney diseases that can reoccur after transplant. So some of the glomerulonephritis can occur. And I've talked a little bit about in the past with other lectures about how GNs by themselves are more of a histologic description of what the kidney looks like under the microscope, but does not necessarily define a disease process. So there are some disease processes that we do know can reoccur. So lupus being one of them. If you try and transplant lupus patients within 6 months of their last clinical activity, it reoccurs in transplant. And it's a real bugaboo to try and deal with, because if it's reoccurred through our immunosuppression and we're using Cellcept and prednisone and Prograf, then you've got a problem as far as what drugs are you jumping to next. You jump into Cytoxan, you jump into rituximab on top of other immunosuppression. You're already hitting them with the drugs of last resort, and you're taking people and immunosuppressing them who have already got a lot of issues going on. It's not a good idea. So we can do lupus patients, but we need to make sure that they haven't had any clinically active disease for at least 6 months. I try to get them out to a year of no clinical activity. And if they're on immunosuppression to control that, it needs to be a low level of immunosuppression. So if they're getting real high doses of Cytoxan, or if they're getting, rituximab monthly, then it's going to be with prednisone and Plaquenil and other things. And it may be a discussion of this may not actually be a clinically quiescent disease. We might not want to put a kidney in them. There are some viral diseases. We mentioned infections can be a problem with transplant, but we do transplant patients who have hepatitis infections. We used to do a lot more hepatitis C than we do nowadays. These direct antiviral agents have done a huge service for us in terms of getting rid of a lot of these diseases. But if you look at hepatitis B, we do some transplants in that area, but it's not one of our viruses that's a favorite one. They don't tend to do well. The drugs that we have to try and manage the disease are just that. They more manage rather than cure, whereas the hepatitis C drugs can cure them. And if you look at the graft failure rates, that those that have hepatitis B do die at higher rates than those that don't have hepatitis B. And those that have hepatitis C also die at higher rates. So, if they're real healthy and we think they're going to get benefits, we still transplant them if they have it. But our preference is to not do those patients. HIV is the same way. HIV's become much more routine now in the transplant population. And when I first came here, we were not transplanting any HIV positive patients at all. And we're now doing that here. We've only had one patient that we've transplanted, but we've got more that we've put on the list. And we're, as their time gains, and we'll start seeing more transplants being done. But HIV is one of those funny diseases where, before we thought it would be a death sentence if you immunosuppressed patients, but they do seem to get the same benefits as the regular dialysis population. They just, in some instances, they don't do quite as well as the others. And so we have some very strict criteria we look at, that they have to have viral loads that have been undetectable for 6 months with an ultra quantitative test. It depends what antiviral agents they're on, because some of the agents can interact with our medications. They can't have any opportunistic infections, and their CD4 counts have to be above 200. But if you transplant HIV patients with those criteria, they do great. All right, so just what are some of the routine workups that we do when we're looking at people? It's a lot of the stuff that you would do when you're looking at a regular operative candidate. So we would do routine blood tests. We would do routine cardiac workup. We do a little bit of screening for cancers. So for men, we might look at the PSAs, which that's gotten a little more controversial in this day and age, but we still use that as a marker for it. And then we do some transplant specific tests where we look at certain viral diseases. So most of us have had cytomegalovirus. We don't think about it. We were sick when we were kids. Mama said, yeah, you were sick, you had diarrhea, you had a fever, nobody tested us for it. But if we look at the kidney donor population and the general population, about 95% of us have antibodies against CMV. But CMV is one of those diseases that can lay around in the body in a latent state for a very long period of time. And so if you look at patients who are recipients of CMV positive organs, when they're CMV negative, they have about a 60 to 80% chance of picking up active CMV disease after the transplant. So they never had it in their body. So obviously it's come in with the kidney and somebody who doesn't have any symptoms of CMV, but it's been laying latent for 20, 30 years and can still show up. And so we would like to know what kind of risk factors we're dealing with. Luckily, in this day and age, we've got antiviral agents that are very effective in terms of preventing relapse of CMV and can even treat it, but the drugs are very expensive. So a month's treatment with Valsite is probably, about $4,000. So it's pretty expensive. The other tests that we talked about, we do the regular cardiac testing, look at EKGs, look at echoes. We do age-appropriate cancer screening. So it's just another thing that's, when you think about just the finances of an overall hospital system, when you think about transplant, there's the hospital benefit from doing the transplant procedure from the surgery, but there's also this big halo effect of being at a transplant center. So transplant nephrologists generate lots of other tests for people. So we order echocardiograms, we order cardiac consultation, we order stress tests, we order catheterizations, we get chest x-rays, we get renal imaging. And so it becomes a collaborative environment where it's generating good health screening for these patients. But as doctors who are working with transplant people, you have to understand what they're looking for. So one of the things that I have to have a conversation with for those people who go into cardiology is to say, okay, well, when I send you to somebody for a pre-transplant evaluation, I'm asking you, can this patient survive the vascular surgery? I'm asking you, can they survive the vascular surgery, and do they have a reasonable chance of being alive 5 years from now? And those questions are subtly different. Or if I'm sending you somebody who's got a echocardiogram and their RVSP is up, I'm wanting you to look at that and tell me, do I think this is a volume issue and transplant's going to fix the problem they have with their pulmonary hypertension, or do they have true primary pulmonary hypertension due to some other issue, whether it's vascular reactivity or chronic microthrombi or things like that? So, I'm anticipating that you're going to do a right-sided heart cath and look at it. And so it's, if you do work in centers, if you're in a non-transplant field and you've got transplant docs referring to you, you want to have some conversations to understand what are they looking for and what's the actual questions that are there. And so I'll get a few people who I like working with who know what I'm thinking, and then I send my patients to them. So I think, the rest of that workup is fairly obvious. So, I hope it's not too boring a subject for you guys, but I just really think it's important for people to understand what some of the other specialties are doing outside of the fields that you may be going into, so that you understand a little bit about what they're doing, what questions they're asking. And then if patients come to you, you have a little bit of an understanding for what transplantation is, and you just don't say, oh yeah, kidney transplants are great. Well, they may be great for some patients, but they're not great for everybody. And, and you can have a little bit of a cogent discussion, because I can't tell you how many times I've seen somebody in the ICU and they've just had a massive hemorrhagic stroke. They're throwing emboli everywhere. The kidney's shut down. And the family said, well, somebody's told me that we could get a kidney transplant. I'm like, no. So we just need to make sure that the messaging out there is stable. It is the same. All right, any questions?
So you mentioned the organ shortage. I know there's been extensive research into xenotransplantation. I wonder if you have any thoughts on it. Is that something that we may encounter?
Yeah, so for those who are on the Zoom, the question is about organ shortages and xenotransplants. So it's a really timely question, and there's a couple of things that have happened in the recent history that's made this a potential possibility. So one of the problems that we have with using xenotransplants is finding a animal that is of relative human size to us. So it's got enough kidney mass to do what we need to do, but yet has enough biologic similarity that our bodies could take the organ. And so primates would be obviously the more ideal setting in that area, but a lot of the primates are small. And so if we were going to try and use large primates, then we're going to have an organ shortage problem because, you know, there's not that many large primates that are around. And humans tend to like large primates. They think they're cute and cuddly. And so it's a lot of ethical problems with going and slaughtering a gorilla. And there's not, you know, I'm in full agreement with that. People don't seem to have that same problem with pigs. You know, we slaughter pigs all the time. So the porcine model has been the model that's been most looked at. And we've been able to genetically modify. So one of the problems with the porcine model is that you guys have heard about these tick-borne allergies, that, you know, that's the meat allergy against alpha-gal. So alpha-gal is a surface sugar that's found in most non-human primates that use milk to raise their young. So it's found in pigs and cows and other ungulates and things like that. And humans naturally carry antibodies against alpha-gal, whether it's come through, it's just exposure through food or things like that. So we can tolerate it from a oral perspective in most cases, but sometimes we can break that, that barrier. And so with some tick-borne diseases, they feed on an animal that's got alpha-gal. They bite on you for a blood meal, and as they're putting out their anticoagulants, you get a little bit of an exposure to the antigen through a non-oral route. And then that can break the tolerance that we have, and you can develop anti-gal antibodies, and then humans can't eat meats. But if you try and do a blood transfusion, or if you try and do an organ transplant with a pig, we have enough of that alpha-gal in the non-allergic people to react against that organ, and we get hyperacute rejection. So they've been able to genetically engineer pigs that don't have alpha-gal. So we thought that was going to solve the problem, and it didn't. So there's some other things like anti-CD45O and these other surface proteins that are there. So now we've got these pigs that are triple knockouts against most of the antigens that we carry naturally. And under the guise of very heavy immunosuppression, we've been able to make pig kidneys survive in the primate model for 2 to 3 years. So it looks encouraging as a potential source, but there's still rejection that's lost, and we're still having to use immunosuppression at such a heavy level. There's infectious complications, you know, that can occur. And there's this risk of something called the porcine endogenous retrovirus that exists. And so people are worried that we're going to get PERV from the pigs. So they're having to try and raise these pigs in a porcine endogenous retroviral free environment, things like that. But they did the very first human transplant of a pig kidney into a human and somebody who was already dead. So they were brain dead. They had 48 hours, and they did a pig implantation from one of these genetic knockouts, and they did not lose the organ from hyperacute rejection. So that's paving the pathway for the first clinical trials, which haven't been done yet, but they're coming. And so you're going to see this in your lifespan as to in the next 5 years. And we're going to start getting data from the human trials saying, how are these pig kidneys doing in humans? Whether that becomes widespread or not remains to be seen, but it's heading that way. The other thing you probably hear a lot about are these artificial kidneys that are wearable. So there's another group of biotechnicians who've made implantable filters that you put inside somebody, and you use their blood pressure to drive fluid through the filter, and then you have a drainage for the effluent that would be created either through an ostomy or some other site, so that you would let the plasma effluent go away. And they've done that in the dog, and they've been able to get those to survive, you know, for a period of time, like 3 months or so. The problem is they have clotting issues. The other problem is if you think about GFR, is that we create 180 liters of a plasma ultrafiltrate every day, and then we reabsorb 99% of that fluid to so that we concentrate those poisons. Right now, we can make the effluent in the artificial kidneys. We haven't been able to figure out a concentrating mechanism that works inside the body. So for the dogs, they're getting very poor clearances because they can only tolerate maybe 5 or 6 liters of ultrafiltrate in a day, and then they have to eat and drink that to keep it up. And so you're not going to get a human who's going to eat and drink 180 liters a day to get good GFR. But those are things that are coming down the pipeline that they're looking at. But right now, we're still basically stuck in nephrology with technology that existed in the 60s when they first made dialysis machines. There's been, a few tweaks here and there, but fundamentally there haven't been any major advancements in the dialysis world. I hope that answered that. Any other questions? Nope. All right, thank you all.
Yeah.
Something else like the.